Dialectical Behavior Therapy by Gregory Watson. Today I'm going to give you the history and theoretical foundation of DBT, including a word about Marsha M. Linehan, the basis of DBT comprising of emotion, dysregulation and regulation, biosocial theory, the invalidating environment and the consequences, Dbt Skills Training, the Standard Dbt Program, Dbt Skills Modules, stages of treatment, evidence base, barriers and obstacles, Dbt and Telehealth, patient demo, references, and finally, discussion questions. Dialectical Behavior Therapy, or DBT, was developed by Marsha M. Linehan, Ph.D., ABPP, between 1984 and 1993. It is a comprehensive, structured treatment for disorders involving serious emotional dysregulation and chronic suicidality. It blends principles of cognitive behavioral therapy with humanistic unconditional acceptance and Zen principles of mindfulness. Born in Tulsa, Oklahoma in 1943, Marsha M. Linehan was the third of 6 children. A precocious child, good student and talented musician, her childhood contained nothing remarkable, no trauma or distress outside of feelings of inferiority in comparison to her siblings, and frequently getting in trouble at home. However, in her senior year of high school, she experienced severe and disabling headaches. Upon the advice of a local psychiatrist, she was institutionalized and diagnosed with schizophrenia at age 17 and exhibited significant self-injurious behavior. She was treated with thorazine, lithium, and electroshock therapy and kept in seclusion on a locked ward. After just over 2 years, she was released and eventually, after many failed suicide attempts and a couple of further hospitalizations, found a job and started taking night classes. She committed herself to Catholicism, the faith of her upbringing, and eventually had a religious experience that left her profoundly transformed. It was after this that she went through a painful breakup that caused many of her feelings of instability and distress to return, but she did not return to her self-injurious behavior. In 1971, she earned her PhD and began working with chronically suicidal patients as both a clinician and researcher. This led her to working with a clinical population well known for suicidality, individuals diagnosed with borderline personality disorder, or BPD. She began to identify trends and responses from the chronically suicidal and borderline personality disorder patients. When using purely behavioral approaches, patients often felt blamed and shamed. When using purely humanistic approaches, patients felt supported and accepted, but change was not forthcoming. DBT was the product of years of experimentation with a range of approaches and the development of a comprehensive system.
I've been transformed by the very therapy that I developed, because once I realized that I had to teach the clients acceptance, I realized at that very same moment in my own personal life, I had somehow lost my ability to accept, and that I was going to have to learn it myself. And so I ended up taking a sabbatical point or time off from my job. What I found out when I went to the first Buddhist monastery was within days I knew that I had found exactly what my clients needed. I had no doubts about it. I figured that out right away. That acceptance was exactly what they needed, but that they had a way of teaching it that I could translate. My problem was I tried to take it stock and barrel to my clients. At Shasta Abbey, the basic message was all the time to try to radically accept everything and to let go of desires and what you want. So we got jobs every single morning. And so it was the idea of practicing letting go of wanting a particular job. If you were sweeping, they would tell you when the bell rang for work to stop They would tell you, stop in the middle, because finishing is just your own thing. You're trying to do something you want to do, just let go. So it was this whole practice of just constantly, moment by moment, letting go of what you want and radically accepting what is. It was the first environment I'd ever been in. It was completely non-sexist. I thought I'd die and gone to heaven. I'm not kidding. It was so unbelievable. Men and women would get the same jobs. There was no real distinction. I mean, admittedly, it may not have been helpful if I hadn't just completely thrown myself into it. But since I'd decided ahead of time that I had to learn this, my only option was just to do everything I was told. Just throw myself in. And I was a student, so there were 8 of us. We did everything together. It was really the practice of letting go of having to have what you wanted at any moment. And the recognition that you didn't have to always have whatever it was you wanted. That had a big effect in some ways on the therapy, that in the sense that I try to teach clients, suppressing what you want is not the way to go. You have to radically accept that you want something you don't have, and it's not a catastrophe. And so I stayed there for 2 months. Then I went to Germany to the Catholic priest. It was actually the first time in my life I ever talked to someone who actually understood me, the spiritual part of me. Given that my spiritual part of myself is the core of myself, more central than anything else about me, having that understood was an amazing experience. It had a transformative effect on me. What it did is it gave me a home. I am now convinced that it was the practice of radical acceptance every moment that will transform you. I don't have the slightest doubt. It would transform everyone. But it has to be a regular practice. And radical acceptance doesn't mean you don't try to change things, because you only have to radically accept the moment that you're in and the past. But you can try to change the next moment. You can't change anything if you don't accept it, because if you don't accept it, you'll try to change something else that you think is reality. So radical acceptance is simply the radical acceptance that reality is what it is. And if you want to change it, then you work on changing it, which is perfectly legitimate also. But I think it's hard to change something if you don't accept it in the first place.
Dr. Linehan's first order of business when creating DBT was to develop a coherent theory that would allow her to understand suicide in general, as well as within the context of BPD. She identified 3 essential criteria for her theory. It had to guide treatment implementation, inspire compassion, and have empirical support. Dr. Linehan hypothesized that, at their core, suicide being a response to overwhelming suffering, and BPD being a serious mental disorder originating from extensive disruption of the affective system, were essentially disorders of emotion dysregulation. Unstable affect regulation is one of several unstable characteristics of BPD, the others being impulse control, interpersonal relationships, and self-image. But first, what are emotions? Linehan posits that emotions are brief, involuntary, full-system patterned responses to internal and external stimuli. DBT places importance on the concept that understanding emotions offers evolutionary adaptive value and consists of the following subsystems: emotional vulnerability to cues, internal and/or external events that, when attended to, serve as emotional cues or triggers, appraisal and interpretation of cues, response tendencies, including neurological, physiological, experiential responses, and action urges, non-verbal and verbal expressive responses and actions, and the after effects of the initial emotional firing, including secondary emotions. Linehan urges consideration of patterns rather than just consequences when analyzing emotional responses, especially as alteration of one element of a pattern changes the overall result. What is emotion dysregulation? Emotion dysregulation is the inability under normal circumstances to change or regulate emotional cues, experiences, actions, verbal responses, and/or nonverbal expressions despite the level of effort. It becomes pervasive when the inability to regulate emotion is present across a wide variety of emotions, problems, or situations. This type of pervasive emotion dysregulation is associated with high emotionality, especially an inability to control intense affective responses. Some of the characteristics regarding emotion dysregulation include an excess of painful emotional experiences, an inability to control arousal, difficulty ignoring emotional cues, cognitive distortions and failure with information processing, difficulty acting impulsively during highly positive or negative affect, failure of executive function to achieve non-mood dependent goals when aroused, and freezing or dissociation under high levels of stress. Emotion dysregulation can also present as emotional suppression, causing pervasive negative affect, difficulty upregulating emotions, and interference with effective communication. Emotional vulnerability, defined as very high negative affectivity at baseline, sensitivity to emotional stimuli, intense response to emotional stimuli, and a slow return to baseline after emotional arousal, lies at the core of systemic dysregulation of the affective system, accompanied by maladaptive and inadequate modulation strategies. This means that emotion regulation lies in opposition to dysregulation and consists of the ability to successfully inhibit impulsive action during highly positive or negative affect, successfully utilize executive function to achieve external, non-mood dependent goals, successfully self-soothe physiological arousal in the presence of strong emotion, and successfully refocus attention during periods of strong emotion. Because DBT treats these as skills that can be learned and practiced, emotion regulation can begin with conscious control and implemented until they become automatic. Overlearning is encouraged. Sound familiar? It should. This work led Linehan to perceive the etiology of emotion dysregulation as a biosocial theory. In terms of biology, a predisposition towards negative affectivity, high sensitivity to emotion cues, and impulsivity is a precursor to emotion dysregulation. These precursors include heredity, prenatal influence, physical or chemical damage to the brain, and early childhood experiences affecting brain development and function. These factors can catalyze vulnerability and later interruptions in emotion modulation. This is why biological dispositions are individual in nature. Of particular interest are infant temperament, effortful control, and negative affectivity. Effortful control is a term encompassing self-regulatory behaviors such as inhibition of dominant response, planning, and error detection. Effortful control is important in both emotional and behavioral regulation. Effortful control is important in both emotional and behavioral regulation. Therefore, children low on effortful control and high on negative affectivity are typically at risk for pervasive emotion dysregulation and behavioral issues, and often identified by a shy, sad temperament, resistant to comfort and easily frustrated. The social environment can foster these biological precursors by invalidating emotions, failing to model appropriate emotional expression, interacting in a way that encourages emotional arousal, and employing a mismatched parenting style to the child's temperament. It is not difficult to imagine how the family might serve as the poster child for negative social influences on biological predispositions, and, as with ADHD, envisage a bidirectional relationship between social and biological factors. Hypothetically, an individual with minimal biological risk factors could still be at risk for BPD if there is serious incongruence between child and caregiver characteristics or a significant dearth of resources, for example, the presence of a family member with a terminal illness or substance use disorder. A child in an environment with needs that cannot be met are particularly invalidating. Inversely, an environment with an abundance of resources and strong family support can easily foster resilience in a vulnerable child. This perspective led Linehan to propose three primary types of family at risk for BPD: the disorganized family, predominantly neglectful or abusive; the perfect family, suppression of negative emotion is paramount, and the normal family, primarily where mismatched parenting styles is evident. The invalidating environment. One of Linehan's trademarks is her emphasis on an invalidating environment. She sees the primary function of emotion as a method of communication between humans. An invalidated emotion is a message that failed to be received. This failure leads to increased attempts at conveying the message via an escalation of emotion. If the intended recipient does not understand the message, they attempt to de-escalate the increasing emotional state and typically use invalidation. This leads to an ever-escalating cycle of behavior until the recipient yields, stops, and then listens or gives in to demands. This reinforces the escalation. If this reinforcement is intermittent, emotion dysregulation is fully established. For a child with high emotional vulnerability and reactivity, this is especially damaging, as an otherwise supportive environment can elicit erratic, extreme, and inappropriate responses characteristic of an invalidating environment. The responses are often towards private experiences that do not have public accompaniments. For example, thoughts, feelings, and sensations that may not correspond with what is observed. For example, when a child states she is thirsty, in a supportive environment the caregiver provides a beverage. In an invalidating environment, the caregiver says, "No, you're not, you just had a drink." A second example, when a child cries, in a supportive environment the caregiver attempts to comfort the child or discover the source of the upset. In an invalidating environment, the caregiver says, "Stop being a crybaby!" In the final example, when a child expresses anger or frustration, in a supportive environment, the caregiver takes it seriously. In an invalidating environment, the caregiver dismisses it as unimportant. A supportive environment takes the child's preferences, beliefs, and thoughts into account. They are elicited and responded to seriously, and emotion is viewed as an important element of communication. An invalidating environment responds to the communication of thoughts and emotions with withdrawal or extreme consequences. A child suffering such a discrepancy between their internal and external experiences, the intense difference between their private experience and their experience of invalidating environment, creates the developmental foundation for behavioral problems associated with emotion dysregulation. An invalidating environment trivializes an individual's experience of pain and suffering, discourages the expression of negative emotion, and instead relates such expressions to negative traits, lack of motivation, lack of discipline, and failure of positive expectancy. The same can be said of strong positive experiences and emotions. Positive experiences instead can be linked to impulsivity or poor judgment. Diversity components can feature heavily in invalidating environments. For example, discrimination against the child on basis of sex, sexuality, or other immutable characteristic can lead to the restriction of requests made by the child on their environment and the use of punishment to control the child via criticism, physical correction, and sometimes sexual abuse. All of these components encourage emotion dysregulation through a lack of opportunity to teach labeling and modulation of arousal, distress tolerance, and a trust in personal emotional responses. It forces the child to look for external signals on appropriate ways to feel and behave, and this externalization leads to an inadequacy in realistic goal setting. The family eventually bounces from extreme to extreme, namely inhibition and disinhibition, the result of reinforcing erratic communication when the child escalates after their negative emotional expression was prevented or discouraged. This style strips ordinary emotions of their ability to effectively communicate in their normal fashion. It is important to remember, however, that not all emotions, beliefs, or preferences can be received or responded to positively. Teaching self-control to children requires a consistent and appropriate amount of invalidation. For example, an overly emotional child will prompt individuals in the environment, such as parents, peers, and educators, to demonstrate efforts to moderate emotionality externally. This type of invalidation can be valuable in the short term, but this is not the same as an invalidating environment. Moreover, the effects of invalidation are different for both resilient and vulnerable children. Adding trauma to this pattern of pervasive emotion dysregulation further complicates Bpd etiology, as estimates put that 60 to 75% of Bpd individuals have a history of childhood trauma. 90% of Bpd inpatients have experienced verbal, emotional, physical, and/or sexual abuse as an adult, significantly higher than comparison individuals experiencing personality disorders other than Bpd. It is not clear whether trauma has a direct causal role in the formation of Bpd, or if both trauma and Bpd share an origin in family dysfunction and invalidation. The consequences of emotion dysregulation. Now that we've seen a brief etiology of emotion dysregulation, it's time to look at the consequences that can result. Self-regulatory behavior, such as effortful control and the ability to inhibit and control affect, is an extremely important part of childhood development. Without the ability to regulate the experience and expression of emotion, goal-directed and prosocial behavior is easily disrupted. This disruption allows strong emotion to catalyze actions into competition with less emotionally driven behavior. Therefore, emotion dysregulation and the accompanying maladaptive strategies manifest the behaviors and reactions that define individuals diagnosed with emotional disorders. For example, impulsive, self-injurious, and suicidal behaviors are very effective at regulating emotions, even if they are maladaptive. Taking an overdose, if unsuccessful, can result in an extended period of sleep, which serves as an escape from emotion dysregulation. Self-injury, such as cutting, results in individuals reporting experiences of relief from depression and anxiety. The method by which self-injury achieves this is not yet well understood. Suicidal and self-injurious behavior are effective ways in which an individual can have their demands met by the environment without necessarily changing or confronting situations that cause pain and suffering. It's not difficult to see how these actions are the result of a pattern of escalation in an otherwise invalidating environment. A common example of this is the admittance of a non-psychotic individual to a crisis stabilization unit. An important note in dealing with suicidal ideation and fantasy. For individuals with emotion dysregulation, engaging in these behaviors can elicit a great feeling of relief, as well as how engaging in self-injurious behavior can be a welcome distraction. While it is important to always take these things seriously, understanding the origin, function, and impact of these behaviors alter how a clinician moves through these volatile periods with such patients. It is difficult to form and maintain a stable sense of self without a fully developed ability to regulate emotional arousal, as this is established through observations of oneself and the reactions of others to our actions. Consistent, predictable behavior over time, across similar contexts, are vital in identity formation. Unpredictable emotional ability leads to unpredictable behavior and cognitive inconsistency, and consequently interferes with identity development. Attempts at emotional response inhibition contribute towards a sense of identity for dysregulated individuals, but this inhibition manifests as emotional numbness or emptiness, which then fuels a weak or missing sense of self. Likewise, an individual in an invalidating environment is only ever sporadically correct about their sense of self and events, further encouraging an over-reliance on others. With an unstable sense of self and an inability for spontaneous emotional expression, interpersonal relationships become very difficult as they depend on distress tolerance and emotion regulation. It is no wonder that chaotic relationships are the hallmark of individuals with emotion dysregulation. Struggles with negative emotionality and impulsivity, especially expressions of anger, are devastating and drastically reduce the potential for a stable and fulfilling relationship.
there's no reason for her to be afraid of me. I would not harm her or anything.
Mm-hmm. Have you ever harmed her before? Hit her, pushed her, done anything like that?
There were some minor incidents, and maybe there was, well, the other therapist talked about that a long time, a very long time, about me being aggressive.
Mm-hmm.
But on the other hand, talking about killing your baby, isn't that aggressive as well?
Mm-hmm.
So who's aggressive?
Mm-hmm.
And they were expecting that I would sit there and listen,
mm-hmm.
very calm,
mm-hmm.
indifferent about
mm-hmm.
her making plans about killing my baby,
mm-hmm.
and not losing my temper.
Mm-hmm.
Of course I lost my temper then.
Mm-hmm.
And of course I did things that I regret.
Like what?
Well, at one point, there's been a moment that she tried to, that I held her, and she tried to run away, and by accident her finger broke.
Mm-hmm.
But that was not on purpose,
mm-hmm.
and it was not my intention to harm her.
Mm-hmm.
But by hiding from me,
Uh-huh.
she was hitting me as well.
Uh-huh. So what'd you do?
Hit her.
Physically, though?
Yes.
Okay. So part of your relationship was that you were hitting her physically.
And the other part was that she was hitting me.
Psychologically.
Yeah.
Okay. Those are different, though. They feel the same.
Yeah, they feel the same.
They may feel the same. I grant you, they may feel the same. But they are different. To physically hit someone is different than to hurt them psychologically.
If I had a choice,
Uh-huh.
I would rather that she hit me
Yeah.
than that she hit me in the way she did.
Yeah.
So for me, there's a difference, but
Yeah,
the
yeah.
other way around, as you put it.
Yeah, that it hurts more to be hurt psychologically.
Yeah.
Yeah, no, I think a lot of people probably feel the same way. It's probably not an uncommon way to feel. Okay, so that makes sense. Do you want a therapist, though, who will help you see the things you are doing that you might not be aware of?
Yes.
You realize that'll be painful. I mean, do you realize that? I mean, surely you do, because it seems to me like this has been somewhat of a painful interaction itself. Has this been painful? Yeah. So that's one thing about therapy, I have to tell you. Therapy is usually very painful. One of the painful parts of therapy, among other parts, are that you often see things about yourself that you don't like. So you kind of had to be ready for that before you go into it.
Well, I think it couldn't be worse than the last few months.
Yeah. Okay, so one, you have to see things about yourself you don't like, and the other is often in therapy you have to work on changing things about yourself. You willing to do that?
Again, my first reaction is, why should I change?
Right. So are you willing to change anyway?
So you notice that he said, why should I change? So you may wonder, why didn't I discuss that with him? The reason I didn't discuss it with him is in my own mind I'm thinking, this is irrelevant. The facts of the matter are you're going to have to change, and there's no point in discussing why you have to change. For one, we've already discussed it. You're the only one in therapy. And second, really, I'm thinking in my own mind, tough shit. You'll have to change. So I want to make sure he's on board. So I say, so are you willing to change anyway? In other words, I didn't get into a discussion of why should he change. I want to move him into agreeing that he will change.
The relationship of emotion dysregulation to DBT skills training. Now that we can fully appreciate the connection between mental disorders, emotion dysregulation, and the resulting behaviours, it should make sense that DBT seeks to target skills training. Cognitive distortions and judgmental responses are common results of viewing the world through negative emotionality. Feelings of disconnection, self-contempt, invalidity, and worthlessness are results of a poor sense of self. This is present in both BPD and depression. The first skill set of interest in DBT is mindfulness. Mindfulness being the ability to consciously experience and observe oneself and surrounding events with curiosity and without judgment, to see and articulate reality as it is, to participate in the moment. Mindfulness is the core to all subsequent skill modules, as mindfulness addresses the issue of high emotionality by observing and describing internal and external present events without judgment or distortion of reality. We won't go into that here though, we can wait for Sally. Because the nature of interpersonal relationships for individuals with emotion dysregulation is that of chaos, intensity, and difficulty, interpersonal effectiveness skills are also a focus. These skills allow individuals to let dysfunctional relationships go and establish and maintain stable, positive ones instead. Learning to recognize and appropriately express anger, jealousy, shame, and envy goes a long way to preserving healthy, beneficial relationships. As a core issue in emotion dysregulation is recognizing, describing, labeling, and avoiding emotions, the next skill set focuses on these types of skills. And finally, impulsivity has been mentioned more than once during this presentation, and it's not missing from DBT skills training. Substance use, self-injurious behavior, and other forms of self-destructive impulsivity are targeted in DBT via an approach that prioritizes distress tolerance. This allows the implementation of appropriate coping responses instead of resorting to an established repertoire of maladaptive strategies. Accordingly, this module teaches effective, adaptive distress tolerance.
Then I had to teach distress tolerance skills. So there's two sets of distress tolerance. There's the first set, which is the how to get through a crisis without making things worse. It's a bunch of things that you could do to not escalate a crisis. And the second is how to get through a life that's not the life you want. And that's the one that starts with radical acceptance. So that's that set of skills. And then we have another set that's an optional set, which are the addiction skills. And they have to do with how do you live a life that gets you out of addiction, which means you have to tolerate wanting drugs but not using them. Borderline personality disorder is primarily a pervasive disorder of emotions. It is the inability to regulate emotions. And by emotions, I'm talking about a very broad spectrum. Not only how you feel, but the physiology of emotions, the experience of emotions, and the actions associated with emotions. It's a group of people with extraordinarily intense emotional suffering who are also simultaneously unable to change their suffering and regulate the behavior that comes from that suffering. So the problem there is, how do you teach emotion regulation? So I developed an entire module of strategies for regulating emotions. And those strategies have been taken from the science of emotions and from the evidence-based treatments that treat emotions. You know, if we had a person who had a treatment for one emotion, I simply looked at what do those therapists tell that patient to do, and then I repackaged all that as a skill. I would have to say about half of my patients, if you ask them how they feel, what their emotion is, they're functioning like they're looking in a fog. They look down and they think, I have no idea. They have no idea what their emotion is. So the first thing we have to do is teach them how to do that. And we have strategies which are very effective for that. And then we have to teach them how to regulate. So there are many strategies for regulation. You can look at the vulnerability factors. So often you're very emotional today because of something that happened yesterday, because you didn't sleep, because you didn't eat, because of some stress from yesterday. So one of the things we look at is what are the factors that make you vulnerable to being emotional, and how can you change those factors? So we look at that. We look at what is the prompting event, meaning what happened right before. Is that something that you can change? If you can, that would be teaching problem solving. If you can't change it, we go to the next, which is what's your interpretation or what's your thoughts about that. We have a skill called check the facts. How do you check the facts to see if your interpretations are correct? So on and on. I mean, there are a lot of different sub-skills in emotion regulation. We know that emotion regulation skills are effective. We've got data on just that all by itself. They are effective in teaching people how to regulate emotions. Interpersonal skills have several components. It's how to get what you want while you maintain a relationship, and how to get what you want, maintain a relationship, and keep your own self-respect. So it has those three dimensions to it. So there's three sets of skills. And how to know when to use what skill, and how to know when to ask, and how to know when to say no. So it teaches a lot about timing. We've now added on to these skills in our new version, which is how to find people and get them to like you, how to validate others, how to join conversations, how much to self-disclose or not self-disclose. So it's got all these sorts of things in them. We also have, in the interpersonal skills now, we have a set of what's called walking the middle path skills. How to validate other people, how to be dialectical, which means not going to extremes, how to see other people's point of view and your point of view at the same time. A number of skills like that are in that section.
The Standard Dbt Program. DBT comes as a standardized program created for high-risk multiple diagnosis patients with pervasive severe emotion dysregulation. While the behavior therapy influence is easy to understand, the dialectical component comes from dialectics, which refers to a method of discourse in which individuals holding a different point of view each seek to establish truth through reasoned argument without resorting to emotional appeal or rhetoric. DBT is flexible and operates on principle rather than protocol. DBT is modular in nature, and components can be added or removed as required. DBT has 5 major functions: to enhance an individual's capability by increasing skillful behavior, to improve and maintain the client's motivation to change and to engage with treatment, to ensure that generalization of change occurs through treatment, to enhance a therapist's motivation to deliver effective treatment, to assist the individual in restructuring or changing his or her environment in such a way that it supports and maintains progress and advancement towards goals. DBT has 4 major treatment modes: individual therapy or case management, group or individual skills training, between session skills coaching, and a clinical consultation team. Each mode has a different treatment target and various strategies for reaching these targets. The most important part of each mode is its ability to fulfill a particular function. This is where DBT's flexibility comes into play. As an example, in order to generalize newly learned skills from therapy to everyday life, the context of DBT dictates the role each mode plays. In an inpatient setting, the entire clinical team may model and reinforce the desired skills. In an outpatient setting, this may be facilitated via telephone coaching. The individual therapist serves as the primary therapist and works with the patient to organize treatment in order to meet all functions and reach all goals. Dbt Skills Modules. The dialectic approach is reflected within skills training. Patients must learn to accept themselves as they are and recognize the importance and value of change. This is why skill modules include acceptance and change, as any individual problem can be conceptualized either way. Each skill module is organized into further sections that are typically taught in sequence, but patients can work on a single skill in order to avoid overwhelming them. Skill sets can be incorporated into the next skill module. Some skills are complex and taught in parts to help patients obtain solid understanding and utilization before adding the next. DBT makes good use of worksheets, and when implemented with fidelity, each patient receives a skills training handbook. Now let's look at an example of a skill, wise mind.
So in general, when I'm teaching, the first skill I always teach is the skill of wise mind. And the skill is based on the basic belief that all people have within themselves the ability to be wise. And what you're going to be doing is simply teaching clients how to find their own wisdom. Now, besides wise mind, I have two other kinds of mind. Reasonable mind is when a person is only paying attention to reason itself. How you feel doesn't matter, what you want doesn't matter, what you're hoping for doesn't matter. None of that matters, because what they're looking for is what the facts are. Now we can go right across and run into emotion mind. What I mean by emotion mind is when you overdo emotions. This is when you're being completely controlled by emotions. So now we're going to move to what is wise mind. Wise mind includes the synthesis of both of those, and it's based on the idea that everyone has the capacity for wisdom.
In terms of tracking patient progress, DBT places an emphasis on stages of treatment. Stage 1 includes suicidal or homicidal or other imminently life-threatening behavior. Stage 2 looks at therapy-interfering behavior by the therapist or the client. Stage 3 looks at behavior that severely compromises the client's quality of life, for example, any Access 1 problems, as well as serious problems with relationships, the legal system, employment, academia, illness, or housing. And 4, deficits in behavioral capabilities needed to make life changes. DBT includes a specific suicide risk assessment implemented at the beginning of every individual session, as well as using a DBT diary card for patients to complete weekly that tracks their emotional states, their behaviors, and their skill implementation. DBT also makes use of a great number of other measures for adults, to name a few, such as borderline symptom checklist, lifetime suicide attempt self-injury count, ways of coping checklist, reasons for living inventory, post-traumatic stress disorder checklist, and many others. The importance of patient commitment and consent is crucial for DBT. A patient in a forensic setting is not considered to be in the program until they voluntarily consent and commit. A treatment period is often 6 months to a year, with weekly skill training group sessions, weekly to bi-weekly individual therapy depending on the stage, and phone coaching as needed. Phone coaching includes an on-call therapist available to respond to crises and emergencies, and typically several clinicians rotate through this position. Evidence basis. There is a considerable amount of evidence for DBT across a variety of settings. It has been compiled here. Linehan and her group do a great job of tracking research for DBT, with adults and adolescents diagnosed with BPD, mood disorders, ADHD, eating disorders, and PTSD. Plus, because DBT incorporates techniques from cognitive behavioral therapy, the substantive evidence base for that individual type of intervention can also be applied. Furthermore, while Linehan is a prominent researcher herself, many others have contributed. This can help to reduce the amount of researcher bias within the evidence. Although the standard form of DBT is preferential due to its evidence base, its flexibility allows it to deviate from the standard format as necessary, And more recently, research studies have examined the effectiveness of the different components of the program, in particular the skills training portion. More recently, because of the specific interest into specific components of DBT and their efficacy, I decided to include, for our reading, along with the chapter article by Kerner and Demeth, I provided a randomized clinical trial that compared 3 groups of patients in order to determine whether skills training alone was necessary and or sufficient in reducing suicidality and improving outcomes. So the goal was to evaluate the efficacy of skills training in DBT. It compared 3 groups. Group 1 was DBTS. This group was skills training and case management. Group 2 was DBTI. That's individual therapy and activities group. The third group is DBT Standard or business as usual. This is skills training and individual therapy. It was a single-blind, randomized controlled clinical trial from 2004 to 2010. It incorporated 99 patients, 100% were female, 71% were white, and their mean age was 30.3 years. The criteria for admission to the study was 2 suicide attempts or non-suicidal self-injury acts in the last 5 years, or 1 suicide attempt in the last year, or 1 suicide attempt or non-suicidal self-injury act in the 8 weeks prior to screening. Some of these criteria were modified to allow participants to participate at short notice. Excluded from the study were those with a current psychotic disorder, which included bipolar disorder, anyone that had a seizure disorder, anyone that required primary treatment for another life-threatening condition, for example, severe anorexia nervosa, or anyone who had an IQ of less than 70. The results showed that while all 3 combinations had improvement, Standard DBT was not superior to the other 2 conditions, but the combination of results do suggest that skills training as a component is more effective at reducing suicidality and improving other mental health outcomes. What do you think? We can pause here or move on to the next part. Barriers and obstacles. Some of the major obstacles and barriers to using DBT were identified in a study from 2014. They discovered 3 main themes. Number 1, challenges with program development and staffing and recruiting clients appropriate for DBT. Clinician comments within this theme reflected the fact that DBT requires a significant amount of training and that staff turnover or insufficient numbers of staff to begin with can jeopardize a program's ability to continue providing DBT services. Number 2, lack of administrative support or investment in DBT. Clinicians felt that a major barrier to implementing DBT was a lack of support from clinic management, such as prioritizing other clinical teams or minimal interest in providing evidence-based treatments of BPD. Number 3, time commitment of DBT and a lack of reduction in other clinical responsibilities. Some clinicians stated that the time commitment required of DBT was a burden and that they had difficulty managing both DBT and their heavy caseloads. DBT is certainly not easy to implement. Training is expensive. For example, the DBT Foundational course is $1,250 online for new DBT team members. DBT Intensive is $11,500 per existing DBT team that can consist of 4 to 8 clinicians. Community settings are reluctant to invest in staff with high turnover. One solution would be to implement a program where clinicians either contract to provide services for a defined period after training or pay back the cost of the course, or pay for the cost up front and are reimbursed as they work. For Theme 2, my own subjective experience tells me that there is a generational component involved. I've had my own battles over the years with senior staff getting evidence-based practice implemented, only to have SAMHSA mandated evidence-based approaches ignored. For me personally, this was particularly present when I was working in prevention. A particular individual who was in charge of dispersing funds and writing contracts with local agencies did not want us to follow any of the SAMHSA guidelines, and she wanted us to follow what she had been doing since the early 70s. Obviously, not all clinicians are like that. One solution to this can be to develop a full presentation illustrating how the short-term cost provides a long-term financial reward to the institution and greatly improves outcomes for patients. Certified DBT teams are not ten a penny, and it is quite a desirable treatment approach. For the last theme, in terms of time commitment, a DBT team needs to be implemented wherever possible as a discrete unit. However, it seems that small groups of like-minded clinicians often band together in an effort to persuade their superiors to allow them to start a team on the side. When you add to that the stigma that BPD or emotion dysregulation patients are burdensome, it is hard to convince management that dedicating time to these individuals is worthwhile. This is perhaps the most difficult barrier to overcome, as it impacts all clinicians working outside of private practice. There is never enough time. However, perhaps we can take a full advantage of the opioid crisis funding to implement DB teams for substance use disorders, and then eventually cross over into more traditional mental health outcomes. Dbt and Telehealth. Is DBT ideal for telehealth? Yes and no. Many of the skills and structures in DBT can easily be translated to an online platform. DBT is already available in a self-help form and, like CBT, can be adapted as software. The benefits to this mean that you are getting a consistent protocol that is implemented every single time, and patient monitoring can be done at the point of interface. However, the issues that emotion regulation patients face means that practicing and making connections, dealing with extreme emotions, and understanding maladaptive behavior strategies are more difficult to work on in an online setting. Much of the group work is peer-based. Phones and other electronic devices that may be a distraction are not allowed during sessions. The dynamic in an online forum shifts dramatically. We're experiencing that right now ourselves, and we are an established group. It's also difficult to monitor mindfulness training on a virtual platform. When you're walking around a room and seeing if people are meditating or being peaceful, that's one thing, but staring at 7 cameras simultaneously to see if people are taking an exercise seriously is something else. I would say that for established patients, avoiding triggering abandonment issues makes transferring to an online format vital in circumstances like we found ourselves today. Also, for underserved populations, it might well be a suitable option, as it's probably better than no treatment anyway. Wherever possible though, I do believe that DBT should be delivered in a live format because, like other therapies, the felt dynamic in the room is vital. Before we look at our discussion questions, I'd like to leave you with one last thing.
People with borderline personality disorder experience chronic feelings of emptiness. They often become involved in a series of highly unstable relationships. They are irrational and have a pathological fear of abandonment. In this segment, observe the pattern of Becky's relationships and note the way that she has learned to cope with her limitations.
It's like I feed off of physical contact. And I know the whole thing about babies needing to be touched when they're little, and there's that whole thing. So my feeling probably isn't uncommon, but to me it's just completely overwhelming. It's like I'm a very touchy-feely person if you're in my little circle or whatever, but if I don't get that physical contact, I just that's another trigger. I'll start to go off into one of my cutting phases. It's easier to just be unhappy, because to be happy opens yourself up to, if you're happy about a relationship, then that person can turn around and make a rude comment or break up with you or whatever. And if I think that they're being dishonest with me or that they're going to leave, I start to phase them out so that when they do leave, it's not like you're being ripped up inside again. It doesn't matter if they're actually leaving. We can be at a store and I lose track of them. I can't see them anymore, and I absolutely just flip out just, I can't breathe, I can't be around people. I mean, I hate crowds. Crowds just freak me out. And if I lose the person I'm with, then it just is compounded by 100,000. And then when I find them, I'm not very nice. I'm, where the hell were you? And all sorts of profanities. And then once I calm down, I apologize and realize I was being irrational, but couldn't see that in the moment.
Like many people with borderline personality disorder, Becky has an unstable self-image, and she has difficulty distinguishing between her public and personal persona. Becky is a highly articulate woman, and therapy has helped her to become more aware of the challenges she faces. She is optimistic for the future, and she seems determined both to establish permanent relationships and to find healthier ways to cope with her anxiety.
I don't know really who I am. I'm trying to find out. I know that I'm someone that cares about people. And at moments when I have clarity in my head, I want to do something with my life. Take all the energy that I spend being unhappy and using self-destructive methods for coping. I want to take that energy and do something productive. But after that, it just gets all black and tangled. Confused with who you are and what you think you are. When I'm out and about, I have a face that I let everybody see, and that's, it's not overly happy, but I'll smile and make the small talk and play the politics and just be very nice and congenial, and everyone thinks that you're just wonderful, that you're on this straight path and you couldn't do anything wrong, and sometimes you even get put on a pedestal, things like that, and then you go home and you're left feeling that you're completely not that person that you portrayed at work or school. I hope that I learn enough to be able to cope and deal with my own demons, that I won't need medication, that I won't need therapy, that I'll be able to use what I've learned and what I've been through to turn around and help other people. I don't want to end up being 40 or 50 and look back and go, where did my life go? I spent all this time being miserable, and instead of sitting here complaining about all the things that are wrong, why don't I do something productive with that energy? And I'm getting better. I'm getting better at it. I have a friend that I've had for 5 years, so he made it past the 2-year mark, so I'm proud of that.